Welcome back to part two of our discussion of EMS systems. I'm still Rob McDuffie, and I'm not a doctor, but I do play one on the streets. When I pulled up this slide, I was overwhelmed with possibilities of where it could take me, and a little bit afraid because a lot of those possibilities are far too deep for our discussion. For the benefit of anybody that's been living under a rock for the last 20 years or in a coma, it's a very hot topic, the American healthcare system. It really is. It's contentious at this point. And we hear a lot of rhetoric. We hear a lot of discussions about socialization of medicine versus free market solutions, and people are throwing knives at each other and breaking bottles of each other's head over it. And that's because of a very simple fact that you're going to hear me come back to, and I may emphasize it more than a lot of EMS instructors because it is a fact that the American healthcare system is extremely simple. Stop laughing. In point of fact, it is. I don't know that it's so much simple as it is we're good at it. It's been around a long time. We know how to do it. Only the financing is complicated. That's where all the arguments are coming from. There's a reason for that, because our system is quickly becoming untenable. It can't go on the way it's been going. The baby boomers are getting older. They're retiring. The population in general is getting older. So demand for healthcare services is going to continue to rise. And I might add on that note, more closer to home for us, the need for people like you and me is also going to grow. There's going to be need for EMS personnel and nurses and doctors and nursing assistants and whatever. Healthcare is a boom industry, and it's going to continue to be a boom industry. We have a problem, and that is in the area of finance. And as much as I would love to tear into that world based on things I learned when attaining my master's degree, I won't. I will leave that alone. We may come back to it and touch on different things. The last thing I want is a political discussion, which pretty much limits everything I want to talk about to not talking about it these days. Let's look at the American healthcare system. And they lead off this particular chapter, or this particular part of the chapter, with a list of different types of facilities that you're going to encounter in your EMS career. These are specialty facilities. They have specialties. They may sometimes you have hospitals that have several specialties under one roof. A trauma center. There's a hard rule that you need to remember. This is part of the evolution of the profession as it's come. We used to take people to the closest hospital. I was never taught to do that. I was taught what I'm going to teach you. Take patients to the closest appropriate hospital, and there is a difference. I was taught that trauma patients need to be at trauma centers. However, we weren't allowed always to act on that. I hate to bring it up, but one of the reasons why our local hospitals didn't like getting bypassed. They weren't getting those patients. Would it be fair to say that they were more concerned with finances than patients? I'll leave that for you to decide. But there was a lot of heat from those very powerful entities in many places where I worked to not bypass their facilities. Burn centers. In North Carolina, we have one in Winston-Salem. We've got one in Chapel Hill. Very good burn centers. I actually did a clinical rotation at a burn center, and it was very distressing, but it was also very educational. Obstetrical centers. I've never seen a dedicated obstetrical hospital. Well, I tell a lie. I sure did. Women's Hospital in Greensboro. It's dedicated to women's issues, not just obstetrics, but any other problems that a woman might have. That had slipped my mind. I forgot about that. Pediatric centers. I know many hospitals. Duke has a pediatric ICU. I want to say Brody or Vidant does. Down east, Think Baptist does. I'll leave it at that. Poison centers. I've never seen a hospital that was a dedicated poison center. I've seen poison centers. You call them. We keep those numbers on the truck. If somebody gets into something we're not sure how to handle, we call them up. Don't editorialize, Rob. Don't editorialize, Rob. Editorialize. Truthfully, I've never found them all that helpful. I've found, especially in the internet age, I could get online and look up the poison as quick as they could tell me something. Maybe quicker. Still did it. It was protocol, so you had to do it. But it was just protocol. Stroke centers. This is a boom industry here. Every hospital, no matter how big, is falling all over themselves to become a stroke center, and they should. You're going to hear back in the day a lot, but it's to give you some reference as to the movement of treatment. And so I'm going to say it now. Back in the day, stroke patients just weren't a big emergency for us. We went out, we found somebody had a stroke. We're like, yep, they've had a stroke. Put them in a truck, take them non-emergency to our local facility. What they would do generally, if it wasn't immediately life-threatening, was let it run its course. They would give supportive care, wait to evaluate how much damage was done, and recommend rehabilitation services if it was possible. Our focus on that has changed remarkably. We have stroke protocols now. We'll get into those when we get to that particular section. We have places that are designated as stroke centers where certain things are supposed to happen, and it has to happen very quickly. You have a narrow window where you can really do some good. But if you hit that target, more and more people are making full recoveries from strokes. Now, keep in mind, there's a lot of different kinds of strokes. And mostly what I'm talking about now is embolic strokes caused by an embolism. If it's a hemorrhagic stroke, that's a little bit different story. We'll get there. Don't trust me. Cardiac centers, comprehensive care facilities for cardiac patients, have a cath lab. They have protocols in place for dealing specifically. This is another one where we're racing the clock. We have what's called the STEMI protocol, ST elevation MI protocol. We're racing the clock to get them to that cath lab, because if we do, we save a lot of heart muscle. There's an old saying in EMS, time is tissue, and that's very true. When someone's having a heart attack, when their heart or part of their heart is being starved for oxygen, we can make a big difference there if we're on our game. And you'll be taught how to be on your game. Hyperbaric center. Hyperbaric therapy comes and goes. It comes into fashion, and people start using it to treatment. At one point, hyperbaric treatment was recommended for brown recluse bites. That's going to sound a lot weirder to you after you learn about brown recluse bites. But you wouldn't think a spider bite in a hyperbaric chamber. Most of the time when you think hyperbaric chamber, we think diving injuries, things like that. Even that has, I won't say it's become controversial. Sometimes it's the only treatment, only effective therapy out there, but it's not as beloved as it used to be. Hyperbaric chambers are, at least from my perspective, as far as taking patients, are kind of in flux. Spinal injury centers. I'm not going to say a lot about that because, truthfully, in my experience, and granted, it is just my experience here in the wonderful state of the great state of North Carolina. In the state of North Carolina, I associate these with trauma centers. I'm sure there are centers that are for advanced care of the spine and rehabilitation of spinal injuries, but no one's ever said to me, oh, that's a spinal center in any of the hospitals, and I've been to hospitals all over this state, South Carolina and Virginia, so I've never heard anybody say that. Maybe, and I'm sure the reason it's in here is because somewhere in the United States there's a hospital that calls himself a spinal injury center. I'm sure I don't know where. We can look it up. I'm not going to. Psychiatric centers. Oh man, wish we had more of these. I really do. I'm not being funny. In my opinion, my gosh, EMS has become a primary provider of psychiatric care, and that should not be the case. The reason I say that is because we used to have inpatient therapy for really disturbed individuals who needed help and they needed to be cared for 24/7, and somewhere along the line somebody said that was a violation of the rights. So now we're just taking people to the hospital, they evaluate them. Very few people can get into inpatient therapy. They turn them back out on the street so we can pick them up in 3 days. That's why I say EMS has become a psychiatric provider in many ways. We are the ones dealing with the us and the police are dealing with the psychiatric patients. Don't want to preach, but it really troubles me that there are not more facilities for people with emotional or mental problems. It does bother me a whole lot. And insurance has got really funny about covering costs at those facilities. Nice little illustration of the inside of a trauma bay. I don't know for sure, but just from experience, I can tell you a patient is inbound. I don't think this is a stage pick. I think they've got an inbound patient, probably a pretty bad one. They're all gowned up, gloved up, everything else, and they're waiting. Yes, EMTs work beside paramedics and others. I'll just tell you, and I always looked at it this way, you're a team. I never really concerned myself. I wanted to know the level of certification of my partner. And I worked differently when I was working with an EMT, of course, than I did with another paramedic. I won't lie to you, it was a little easier day for me if I didn't have to take all the ALS calls and all, if I had somebody I could switch off with. But it didn't matter. Whoever was on that truck with me, we were a team. You will work alongside of many others. This slide, and I'll go ahead and get it out of the way, EMTs interface with team members from other public safety organizations. Yes, you do. Law enforcement. Matter of fact, I would say that we're interfacing with more of them today than we ever have before. Paramedics are part of special response teams, even within law enforcement. SWAT teams. You have SWAT medics. You have tactical medics. Fire departments, many of them, particularly in metropolitan areas, that aren't the primary provider of EMS. That might be another agency, a county agency, for example. But they hire and place paramedics on their engines, and they're advanced life support first responders. I got a friend in Florida. That's what he does. He's a firefighter medic in the St. Pete area and loves it. I mean, he absolutely loves it because they don't have to transport anybody. He goes out, he renders care, turns them over to the paramedics, who then continue that care and take them to the hospital. So you do work with a lot of teams. Remember Ben? If you don't, I'll give you a brief review. Ben had diabetes and he wasn't in the best of health. I can't remember. He was in his 50s, I believe. Went into his favorite restaurant, and his other friend was there and looked at him and said, "You don't look good." And he takes a header on the floor, and the waitress called 911. Well, we're back with Ben again. After quickly determining the nature of Ben's problem, the EMTs head toward the closest hospital, a 35-minute trip. Sound like some of the places I've worked. With Julie behind the wheel and Peter in the back of the ambulance caring for Ben. Having arranged for a paramedic unit to meet them en route, Peter gives the paramedics a quick radio report. In the jargon, what this unit did was call for an ALS intercept. It really doesn't happen so much in the places where I've worked. Most of your primary responding units have a paramedic on board. But there are places that have a tiered response where I've actually heard of them where they don't even dispatch paramedics until the EMTs get there and call for them. Knew of a couple of places. I knew one in North Carolina that did that, and it didn't work out very well. They abandoned that and started dispatching them both at the same time, which I'm trying to figure out why they ever considered doing otherwise in the first place. But hey, I think about things. That's what I do. And so for this part of the case study, we're being asked, how can requesting a paramedic intercept benefit the patient? And secondly, what are some of the potential pitfalls in patient safety at this phase of the call? Just from what we know, and we don't know a lot, about this patient. We know that this problem that they're having, the patient could benefit from advanced life support and may need it, the sooner the better. I mentioned that time is tissue, and this patient may be deteriorating pretty quickly. So there are a myriad of benefits to calling for it. They got a long response time, 35 minutes to a hospital with a pretty sick patient, sounds like. Ben's not doing well. So a lot goes into a decision for an intercept if you call for one. And I have to be honest with you, like I think I mentioned it, most of the places I work don't have a tiered system like they have a tiered system, but not like this. Paramedics are in the primary response. I mentioned one in North Carolina, and after I talked about it, I thought I should say something. The reason that the one in North Carolina that I know of abandoned it was because they had a pretty bad outcome from the practice. It was a noble effort. It was an attempt to be more fiscally responsible, but there's a really fine balance between financial policies and patient care policies, and in my humble opinion, they should never mix. You should never get your patient care policies and your financial policies mixed up together, because then you have bad outcomes that usually become very public, and more importantly, somebody suffered for it. As for the second part of this question, what are the potential pitfalls in patient safety at this phase of the call? There's a lot of places you could go with that particular question. There is a certain amount, I'm assuming, that our EMTs and our BLS unit are running traffic, emergency traffic. Sometimes I just shorten that to traffic. So there's inherent dangers in that. That was the first thing that popped into my mind. There's inherent dangers. I've read somewhere, and this is an old statistic, so it may have been updated, that you're about 6 times more likely to die just by lighting that unit up. Just by lighting up the ambulance, your chances of dying increase by a factor of 6. So there's inherent dangers in that to everyone involved, including the patient. And then I got to thinking what popped into my head. And remember, I've been doing this a long time, so what pops into my head may not pop into the head of a student. I'm actually have memories of this sort of thing. I have done ALS intercepts. We had, never for a county I worked in, but we had counties surrounding us that did not have paramedics, and it was quite normal for them to call for one of our medics to intercept with them when they had a very bad patient. And I've done that. I've done it several times. I did work in a quick response vehicle, a QRV, in a system that was based, it was a partnership between the rescue squads and volunteer fire departments and the county, where the county provided the paramedics, the rescue squads provided the BLS personnel and the transport unit. I responded in a Tahoe. If they needed a paramedic, I grabbed my gear and I put it on their truck and we rode in. But we responded together. In this scenario, what you've got is a BLS unit that responded, snatched up a patient, and called for an ALS intercept. So other safety factors other than the response itself and the traffic itself, what kind of traffic you're running, come to mind in how do you do that handoff? How do you do it? I've seen it on the side of the road. So there's some more dangers there. And the most efficient way is for the paramedic to grab his or her gear and jump in the back of the BLS unit and keep on trucking. That means there's no necessity of moving a patient from one unit to another, one bed to another, because that could be that the stretchers are not compatible. Seen that happen, where we've had to take a patient off of one stretcher, put them on another in the middle of a call. Moving someone off the floor. We had to get Ben off the floor here. Moving someone has inherent risk. That's why we talk a lot about the proper way to move someone. And I may lose my instructor decoder ring for saying this, but I have to tell you, there are times when there's just no good way of moving someone. You're going to find them in spots where you're not going to be able to use all the little techniques they tell you about how to do, how to keep your back straight. It's just not going to happen. It's one reason why we are prone to injury. because a lot of these people, and I'm not trying to be funny, are dead weight. They're not helping you at all. And if you don't, I don't care how many times you go to the gym, if you got a 160-pound person that is dead weight, they don't come with handles. So it's very difficult to move them around. And that kind of flitted around the back of my consciousness too, that there may be some issues with physically getting Ben off the floor, putting him on the bed, getting him out of the truck, and getting him loaded. There is a science to that, or at the very least it requires some thought. We'll leave it at that. You may think of some other things, and I encourage you to give it some thought. Now we're going to start a discussion of EMT responsibilities. I actually sat down and read this list in your textbook. I counted, I think there's like 15 of them, 16 of them, I forgot now. The old steel trap's not what it used to be. But I always love these lists because they're true. There's nothing wrong with it. It's just, if I put my mind to it and I sat down and really thought and wrote down the responsibilities of an EMT, it'd be a pretty long list. It really would. There's something you need to know, and I should explain why you need to know it. You can go on the internet, and I encourage you to do it as far as that goes, and find the work of other instructors covering this same material. And you'll see you'll see some variants. And the variance is some instructors will run these slides straight. They just run them. They might comment a little bit here or there, but they don't add anything to it. And that's okay. That's fine. I think every instructor has a right to their own teaching style, and they all have a different teaching style, and there's strengths and weaknesses to all of them. In my view, what's the point in having over 3 decades of experience at all levels of this very weird and wonderful profession if you can't pass things on to your students that will help them? I said all that to say this. As far as responsibilities, as far as rules, and as far as procedures, there are as many unwritten rules as there are written rules. Some of them are specific to the profession in general. Some of them are specific to wherever you work. There are a lot of unwritten rules, the things you won't find in your textbook, things that you kind of have to learn. And some of them, sometimes you learn where a landmine is by stepping on it. I'd prefer you didn't. I'd prefer to be able to tell you some things and prepare you for them before. So we're going to talk about each one of these, but just know that this is not an all-encompassing list of your responsibilities. Your responsibilities are expansive. And, to boil it all down to something you can understand, your responsibility is to resolve the situation in front of you legally, safely, appropriately, medically speaking, whatever it may be. And that covers a lot of territory. That covers a whole lot of territory. But let's go through these right quick. Maintain vehicle and equipment readiness. True, very true. Every day, it gets tedious going in and checking out an ambulance every day. Putting your hand on every piece of equipment in it, making sure it's there. But I could tell you stories for the rest of the day about paramedics who arrived on a scene only to find a piece of vital equipment that they needed to resolve that call in a life-threatening situation was either not there or didn't work. I once, quick tip, because I intend to do some videos on how to get employed and remain employable in EMS. And no, that's not in the curriculum as far as the National Registry goes or the National Standard goes, but I feel it's my duty to do that, because if you think about the mission of the community college system, it's not only to create paramedics or whatever, it's to create employees. It's to support the workforce. So I think that's just as much part of your education, or it should be, as anything else. And I'll probably do some videos on some things that, some do's and don'ts in that department. I once one of the things I was going to give you right now, I'll give you this tip right now. The moment you hit that parking lot, you need to be ready to respond. Because I can't tell you how many times I pulled up, showing up for work, only to have the tones drop and have to drop my bag and go jump on the truck to take a call. So make sure that you're in the starting blocks when you pull into the drive. If you don't, it gets really messy. Or it can. It doesn't always, but it can. And that happened to me once. I jumped on the truck. I not even got all the way in the bay. The tones dropped, and I jumped on the truck. And I went out to a very bad respiratory patient, only to find that there was no oxygen on the truck. Now, see, I had not had time to check it out. I just got there. I should have been able to rely on the off-going crew that it was there. But I didn't have any oxygen on that truck. M cylinder was empty. E-tanks was dead. I had none. I had to call for another unit to get oxygen. That is an awful, awful feeling when you've got a very sick patient and you don't have what you need to treat them. Next one's a big one. Ensure the safety of the EMS crew, the patient, and the bystanders at the scene. It starts with you. Your first responsibility as far as safety is you. There's an old expression in EMS, probably been around as long as the profession has, and that is dead rescuers don't help anybody. You must take care of yourself. Be aware of your surroundings. We're going to talk a lot about situational awareness. I think the next chapter is on wellness, and a huge chapter. It's not blood, guts, gore, and glory, but it is extremely important because when you're hurt, when you're crazy, when you're dead, you don't help anybody. You don't help anybody at all. Your partner, in my hierarchy, is me first, my partner second, and then everybody else on the crew that I can protect. There's always people on the scene that is really outside of my control to protect. I could talk a lot about that, but the patient, I'm going to protect. I'm going to make sure I protect the patient to the degree that they will let me. Some patients won't let you protect them. But that's my responsibility. Safety of me, my partner, the responders that I have influence over and that I can protect, and most of all, second to me, of course, the patient. I'm going to protect them. I've had partners that needed protecting and wouldn't allow it. I've probably been in situations where I needed protected and wouldn't allow it. I'm not ripping on anybody. It's a state of mind that you have to be in all the time. Operate the emergency vehicle. It is safe for me to say. It's statistically proven, and also it fits in with my understanding and experience that if you die on this job, it is most likely going to be from a crash. There are other things that can get you. There are other ways that EMS people die. I'm on a listserv that sends me out line of duty deaths from all over the country. And it's depressing, but I think it's important for me to know and to note when my colleagues have fallen. I would say 7 out of 10 of them, just off the top of my head, are from crashes, from vehicular accidents. What can I say about that? I'll say this. Never operate an emergency vehicle faster than you feel comfortable operating it. I don't care what anybody says. It takes time to learn how. To me, truthfully, driving an ambulance is a lost art. We used to really emphasize it. We really don't anymore. But it's not just a matter of driving fast. It's a matter of getting someone where you need to go while not killing your partner in the back who's trying to work on a patient by bouncing him all over the walls and not causing 6 accidents while you're en route to 1. It is a very serious thing. We're granted a lot of authority in operations of vehicles. It may surprise you to know we're not medical legal yet, but there is no speed limit on ambulances. There's some local policies that some counties have that say you won't drive the ambulance any more than 15 miles over the speed limit. But as far as the state of North Carolina, All it says is an ambulance has to be operated with due regard for public safety. And if you crash it, I can promise you they're going to find it wasn't being operated in due regard for public safety, especially if somebody else gets hurt. So yeah, we have to operate emergency vehicles. Everything about operation emergency vehicle is important. Where you place it on the scene of an accident, where you park it. You know, shut up, Rob, move on. Assess the patient. We're going to talk about this. Of course you have to assess the patient. Everything, if you don't do that, everything else we teach is moot. You've got to do a proper assessment. And this is a skill. It takes practice. It takes calmness. You have to be able to look at a pretty bad patient and assess them dispassionately. You're looking for injuries. You're looking for things that are going to kill them. And I'll give you a little tip, a little preview of things to come. Many, many times it's not the big, gross, nasty-looking injuries that are the problem. They're the ugliest, and they draw our attention to them because they are. But it's the ones you don't see. It's the hidden ones. It's the ones that don't show so much on the outside. That's probably going to be the ones that are most deadly to your patient. Not always, but most of the time. Provide emergency care. Well, I would think so. That's kind of what we're all here to learn how to do. Safely, I'm having, Mr. Tongue and Mr. Lips are not working together today. Safely lift and move the patient. There's an art to this too. It takes some thought. You need to think through what you're going to do before you do it. See, a lot of people forget this step. See, a lot of people pay for it. Sometimes I see the patient pay for it. It's not a brute force proposition, although sometimes brute force is part of it. You have to think about what you're going to do because you don't want to hurt the patient and you don't want to hurt yourself or see anybody else get hurt. Prepare oral and written reports. You will grow to hate these. They're just part of the job. They're as much part of the job as anything else. And speaking as someone who spent a lot of my career fact-checking, quality checking reports of others, I can tell you there's some people that are really good at it, and there's some people that really aren't. And if you really aren't, you're taking a big risk. You're taking a very big risk. If you go to court, that report's going to feature prominently. And if it looks like it was written by a fourth grader, some attorney's going to eat your lunch. I can promise you. Safely transport the patient. That goes back to operating an emergency vehicle. Matter of fact, I think that was kind of redundant. Probably didn't need to be on this list. It's kind of inferred, but whatever. Transfer patient care. You can't go into a hospital, toss a patient on the bed, and leave. You are responsible for giving a report. Most of the time, this is going to happen for the receiving nurse. You give that report. You are obligated to do it. The nurse is obligated to receive it. If either one of you doesn't do your jobs, then you could have some legal issues. And more importantly, something could slip through the cracks regarding that patient, something very important. Remember, gang, we see things that the people at the hospital do not. We see the patient's natural habitat. We see the circumstances surrounding whatever's happened to them. We see the mechanisms of injury a lot of times that the hospital people do not. It's incumbent upon us to relay that information to the receiving facility so that they can use it in the continuation of the care of that patient. Perform record keeping and data collection. We're kind of fortunate in this respect because I don't, as a paramedic on a truck, I don't perform record keeping. I perform record writing, but I don't perform record keeping. Most of your software that we're using now to do ambulance call reports or ACRs, what we used to call them, now it's patient care reports or PCR, they're designed in such a way that the data collection happens as a part of your regular documentation duties. You're going to have questions on of course you're going to have demographic data and you may have other questions, but the data is then mined from the reports and fed into a database so you can pull up statistics in most of them. Otherwise, I can't imagine doing any other type of data collection or record keeping. Serve as the patient's advocate. This is a big one, and I should tell you quickly, it may be one of the harder parts of the job. There are some people that will not let you be an advocate for them. There are some people that, if people ask me if you could cure a disease, what would it be? I'd say stupidity, ignorance. Because there are people out there, by their own ignorance, won't let you be their advocate. It's still your duty to try. What that means in basic terms is it's my job to do what is in that patient's best interest, not in my interest, not in the family's interest, but that patient's interest. And there's many cases when you're the only advocate, at least initially, you're the only advocate they got. They can't speak for themselves. You're the one that has to advocate for them. It's frustrating when a patient will not let you, when you're trying to help them and they're rejecting you. You get pulled into that a lot. You still have a responsibility to try. You still have a responsibility to do what you can. And going back to writing those reports that will make you crazy sometimes, if a patient's not letting you be their advocate, that better be reflected in the call report. That better be, because if it's not, it just looks like you didn't do your job. Provide emotional support to the patient, relatives, and others at the scene. And this, if I have to be old and crotchety, and I will be because I am, this is where a lot of medics fall short. A lot of good medics fall short. I've known medics that, medically speaking and tactically speaking, were as good as I've ever seen, but they were a-holes to the family and relatives and others. And a lot of ways you can look at that. Number one, if they're a great paramedic and I'm the patient, okay, I'm getting what I need. But from an employer standpoint or a professional standpoint, you can actually hurt yourself and your service by doing this. And I'm not going to sit here and tell you that I've never popped off at a family member. What was the movie? I can't remember. Be Nice. I think it was Patrick Swayze. It might have been Roadhouse. Be nice till it's time not to be nice anymore. There are times when you just have to be frank with people and direct with people. There's nothing wrong with that. Abusive to people? No. Unnecessarily short. You have to remember, and it gets hard to remember. Remember, this is our business. This is what we do every day. We are the guest star in everybody's nightmare. Every day we see people at their worst. It becomes routine for us, sort of. We'll talk more about that in well-being. But to them, this is a pretty bad moment. Don't make it worse. Don't make it worse. It may feel good. There's a rule of thumb for me. If I said something that felt really good, it was probably the wrong thing to say. It felt good, but it was probably not the right thing to say. Emotional support. Sometimes, boys and girls, that's all you can do. There's no way that I can make a family who's just lost a child feel better, or I can't cure them. I can't make it go away. It's happened. But I can be supportive. Anyway, let's move on. Integrate the EMS service with other emergency and non-emergency services. I personally think we do a fairly decent job of this. I've been very blessed. I read things from other areas of the country. I see videos on YouTube where cops and medics are at each other's throats, and firefighters and medics. I've not experienced very much of that. I've ran across a couple of jerks in my time. Don't get me wrong. Every agency has them. You can't get away from them. But I've always enjoyed a reasonably good relationship with the people that I worked with, the other agencies. And fortunately, there are exceptions. You'll probably hear all about them before you get out of here. But we always tended to work very well together. We didn't often get in each other's way. I attribute well, part of that may be where I'm at. I'm in North Carolina. People here tend to be friendly anyway, and we were raised to be respectful to one another for the most part. But I think it has to do with training. I think we do a lot more cross training today than we used to. Still not enough. We still train in a vacuum in our own little silos. EMS trains EMS, fire trains fire, law enforcement trains law enforcement, and yet when something big happens, we're all there. And we've never trained together. So we'll talk about that too, particularly as it relates to mass casualty incidents. Be a good rep. Remember, the patient's paramount. That's what we're there for, or patients, maybe more of them. But represent your service well. Treat your fellow responders with respect. They're just as proud and just as type A as you are. Try not to go out of your way to alienate them. I'm telling you, to me, a paramedic pissing off the first responders is a lot like a quarterback pissing off his front line. It just ain't smart. You're going to get eaten. You make them mad, they keep those monsters on the other side of the line from eating you. They'll stop doing that. And we need them to function. I got to resolve the emergency incident. If I have to explain this one too much, we need to sit down and talk. That covers a lot of territory. Resolve the emergency incident, and a thousand scenes just ran through my mind at one time. And yes, we did it, but it's a lot more complicated than a four-word sentence. There's a lot that goes into that, and we'll talk about that as we go along. I'm not going to belabor that one. This thing's getting too long already. Maintain medical and legal standards. You better, or you will be a former EMS professional and quite possibly living in a cardboard box because somebody sued you into the flames of perdition, and maybe even staring at a jail cell, depending on how bad you screwed up. You can be prosecuted. Provide administrative support. I got to be honest with you. I was looking through your book. I don't even know what this means. I can make something up. I don't have to say that. I could always make something. Oh, I know what it means. Provide administrative support. It really, in my mind, when I see that, it is the support. Basically, I think what they're telling you to do is be a good medic and support your chain of command. They may have something totally different in mind. I don't know, and I actually looked for it because that one confused me. But we'll skip over and move to the next one. Enhance professional development. We have a problem with this one sometimes. You are responsible for your certification, not your training officer, not me as your instructor. You are responsible for it. Can't tell you when I was a training officer how many people called me up. Or a better example, when I was over continuing education at a community college, people would call me up. They had done nothing for 4 years. Their certification was coming up for renewal and wanted to know how I could help them. And the short answer is I couldn't. I could not give them 4 years of continuing education in 30 days. It just wasn't going to happen. So get that straight from the get-go. You are responsible for maintaining your credentials. Now, there are people that will help you. Training officers will send out notices. Heck, the state will. The state will send you a notice when your credential's about to expire through email. But it's your responsibility to make sure you maintain what you must maintain to remain certified. Professional development is something a little bit different. That was continuing education. Professional development is things that I mentioned mass casualties. I go to seminars on this. I give seminars on this where we look deeper into issues that maybe we don't do very often. I don't run. When I was on the truck, I didn't run a mass casualty incident, every day, every week, every month. They were thank God, very few and far between, which is one reason why we tend as a group, if we're evaluating our profession and other professions, fire and law enforcement, why as a group we tend to stink at them. Because we don't run them every day and we don't train together to do it. I've already mentioned that. I go now, the college here it's an online program where they train me in different things, law changes, things like that. You're always developing. I told you in the introduction video that I hope you watched, you've condemned yourself to a life of perpetual studenthood if you stay in this profession. You're always going to be a student until your last call when you take that uniform off for the last time. I hope you don't do that on the call because that will get us phone calls. But your last call is when you're done. You're never done with this. You're always learning. Develop and maintain community relations. I want to give you a very practical reason. Be careful, Rob. Be very careful. Public servants, true ones, I'm not talking about elected officials. I'm talking about cops, firefighters, EMS, rescue. We have something of a love-hate relationship with the public. We do this because we care about people. We do it because in its most basis form we believe it to be a good thing to do. But the public can drive you up a tree. The things that they will do, you know, sometimes it's just funny. You get a good laugh out of it. Sometimes it's just maddening and things that people will do. And I'm not just talking about on calls. I'm talking about with politics, you know, the things that are in misunderstandings about who we are, what we do, what we can do, what we can't do. It can drive you crazy. You spend a lot of your time explaining that. But I'm going to give you a practical reason why you need to maintain community relations. Very practical one. If you have, when you get old and salty and you're just about feel like you want to scream at some of the things the public does, there's a good reason to maintain relations, and that is these are the people that are funding your department. If you lose the confidence of the public, it will be reflected in your department. That's your raises, that's your equipment, that's all this, that's your training, that's everything. If you lose the support of the community and the county for EMS purposes, fire departments have to deal a lot with the community that they serve and county citizens because they pay fire taxes in most places I work. You lose that support, you're going to feel it in your pocketbook. You're going to feel it in your wallet. It's going to happen. So not only is it just good to do, it's a smart thing to do, to maintain good community relations. And community relations in the age of the internet have gotten exponentially more complicated. They really have. Back in the day, all we had to worry about was the press. You know, we had to worry about what some reporter was going to write or what was going to happen. Now, everybody's a reporter. Everybody's got a camera. Everybody. It's kind of scary to me because I know that the lay public knows very little about what we do, very little about what law enforcement does. Only they boil it down to the most basic thing, the lowest common denominator, and yet they are out there with cameras and commenting on it. It's frightening, and they're not willing to get themselves educated. They're not doing it to. They're doing it to hurt you. You cannot help the patient, other rescues, or yourself if you are injured, and even less so if you're dead. I've already touched on most of this, so this will be a quick slide. Driving habits. Driving's a lost art. Hopefully going to rectify that in this program here. As a matter of fact, we're going to teach you how to drive. I already know how to drive. You don't know how to drive a 15,000-pound vehicle with a patient in the back and somebody trying to work on them. We're going to teach you how to do that. Do not enter or stay on an unsafe scene. Good advice if you want a long and happy life. We'll talk more about that. You're going to hear so much about safety, scene safety, and protection that you're going to get sick of it, and I don't care. You're going to hear it until hopefully it is burned into your brain. You know why? Because I want you to have a long and happy life. I don't want you to be crippled. I don't want you to be killed. Be alert to situations with a risk for violence, which pretty much encompasses every situation. In my experience, boys and girls, violence can be there when it wasn't there 30 seconds ago. Violence can erupt from within the call and outside of the call. Things happen. You have to be alert. You will develop, or at least I hope you do, an internal sense of when violence is near, or when it's approaching, when it's about to happen, that other people don't. And it's from being close to it and seeing it. You'll get to where you can sense it coming. You know it's coming. Wear reflective clothing and protective clothing is indicated. Don't editorialize. Don't do it again. You said you weren't going to. Boys and girls, if someone is dumb enough, drunk enough, mean enough to drive through one of our scenes, that little yellow vest ain't going to help you. But it is the law, so wear it. I mean, why don't we put screen doors on submarines? That'll help too. No, it's useless. But maybe at night, I'll give you that. At night, of course, I'm usually in a turnout coat or some other, I'm not in the vest. I do believe in wearing it at night when it may be a factor. Wearing it during the day to me is not that effective, but we're going to do it because that is the law. I'm much more concerned with you wearing protective clothing when you need to. We are incredibly cavalier about personal protective gear. And I will say that we have since learned. See, when I was in school and learning to start IV, we didn't wear gloves. We didn't wear gloves when we gave injections. We just weren't taught to. Why? Because nobody was. When AIDS hit and everybody lost their collective minds, and I'm not saying it wasn't a bad time, I'm just saying there was so much misinformation and so much reaction without fact. Well, the next thing you know, they're making us wear gloves, and they wanted us to wear a mask, and at one time they didn't want us wearing our uniforms home. OSHA was talking about making that rule that you could not wear a uniform home. You had to leave it at the station and launder it at the station. Is it a good idea? Probably. You don't want to take something home to your family, but I've been doing it 30 years and I haven't brought anything home to my family yet. Doesn't mean it can't happen, just it hasn't happened. But when I had to start wearing gloves, it was like learning to start IVs all over again. I spent a lot of time taping my fingers together. It was just hard to do. We've since learned that maybe we went a little overboard with the bloodborne, precautions. It was a smart move to switch to safety catheters and safety needles, but the gloves and the gowns and all that stuff in those days, maybe we went a tad overboard. That's not the hill you want to die on. Wear your protective gear. Wear it. You're going to wear it in class when it's appropriate. You're going to wear it in the field when it's appropriate. It just makes your life easier and a bit safer. So wear it. In looking at this picture, I see something very wrong with it. Actually, I see a couple of things very wrong with it, but I can't see all of it. So, just taking the picture on what I can see, I see a vehicle overturned, leaning inward, that doesn't look to be secured to me. It very well may be. I'd like to see all of it, and I'd love to see a couple other angles before I made that judgment. But again, just evaluating this picture on its face, be careful about making snap judgments when you don't have all the facts, guys. That's foolish, and it'll burn you too. And a second thing that I see right off the bat is I see a gentleman over to the right in the blue and gold shirt, or a blue shirt with a gold logo of some type on it, is not in turnouts. Have I been inside of a car without turnouts? Yep, sure have. Not picking on the guy. That person should be in protective gear, should be in turnouts, at least in Nomex of some type. Something you need to know, don't want to get too far into it, but when you have a vehicle crash, you've got everything you need for a pretty good size, at least fire, if not explosion. And it can happen without warning. I've seen it happen without warning. And you may or may not have time to withdraw to a safe distance. That's why we push you to wear protective gear. Nomex jumpsuits, they're flash protection only. I'm not going to fight a fire in a Nomex jumpsuit. It's not what I'm there for. What it's there for when I put it on to get into a vehicle is if that thing does flash, if it goes up unexpectedly, it might buy me enough time to get out of there before I get horribly disfigured or lose my life. That's how quickly these things can happen. Enough said about that picture. I really kind of feel bad about even commenting on the stability of the vehicle because I really don't know. I can't see the whole picture. Patient assessment and emergency care. In this picture, and I'm going to move this quickly because this has already got to be very long, what you see is both of them doing patient assessment in a manner of speaking. Even though the one on the left is the one physically interacting with the patient, the one on the right is gathering information from, assumably, the mother, could be the caregiver of some other type. Information is your friend, guys, and the more you have and the quicker you can assimilate it, the more success you're going to have in this business. Patient transport and en route care en route. Yeah, this is the part of the equation in EMS that the lay public generally doesn't get. That we're not just a transport medium. There was a time in this country when that was the primary focus. We're an intervention business. That's our product, intervention. Transport is part of that, and it's an important part of that. I won't deny it. And there are cases where you're going to find this patient needs help far beyond what I can give them. And then transportation becomes a premium. But you're responsible for that patient from the time you make contact until the time you deliver them. And you have to make interventions sometimes in the back of a bouncy truck. We don't contact medical direction as much as we used to. When I started, there were no standing orders, period. I know that's hard for any of you who have any knowledge of this business to understand, but when I started, unless they were dead, I could give drugs to a dead person. If someone was in cardiac arrest, then I could just go ahead and run my protocol without contacting anyone. I could not stop the resuscitation without contacting anyone, which we do frequently now. We call codes on the scene. We have a protocol. We follow it. Once we ran through that protocol, we need to make a decision on cessation of efforts. But I encourage you, it is a tool in your toolbox, medical direction, that is very important, and you should use it when you need to. There's this stigma, I guess, for lack of a better word, that surrounds this particular tool in your toolbox. Oh, you shouldn't need to call medical direction because you're supposed to know everything. I got news for you. You don't. You don't. And sometimes it's, even doctors call for consults with other doctors. Sometimes it's time to call medical direction. Sometimes it's like, hey, I'm got a mess here, doc. Help me out. And so don't be afraid to use it if you need to. I've already talked about transferring care, so I'm not going to go over it again. Just a reminder that you're responsible for giving the information. You're responsible for giving a report. They're responsible for taking it. Record keeping, again, all I'll do is reiterate, do it well. Take a few extra seconds and write a good report. And we'll talk about how to do that. We get medical legal, we're going to talk about reporting, writing reports, what should go in them, what shouldn't go in them, and so on and so forth. Oh, let's check in with Ben. Ben is at the designated point. The EMTs meet the paramedic unit and give an update on Ben's status. The paramedic, Alexis Brady, further assesses Ben and implements advanced life support ALS treatment. Following the treatment, which was administered to increase Ben's abnormally low heart rate, we're starting to get some information on the cause of Ben's problem. Ben regains consciousness and is confused about what happened, as I imagine he would be. So Ben we've had the intercept. Paramedics got on board, most likely did an assessment, not most likely, definitely did a reassessment, listened to the EMT. If he's smart, he listened to the EMT and then does an assessment and spots an abnormally low heart rate, gives medication for it. Little hint, it's probably atropine. Atropine is kind of fallen out of favor, but I don't have a bit of problem giving it a shot while I'm thinking about other ways of getting someone's abnormally low heart rate up. But if he gave a medication, it was atropine, most likely. So Ben's getting better. Ben's getting better. And we'll move on. Now that Ben is conscious, what do you think are his expectations for how Peter and Alexis interact with him? Well, that's an interesting question. If I'm honest, I doubt he has a whole lot of expectations of anything except somebody tell him what the heck's going on and what's wrong with him. But I'm sure that the case study wants more than that, but in my experience, that's generally what patients want to know. What happened? How did I get here? What's wrong with me? Where are you taking me? How could the nature of those interactions affect the quality of patient care? Now, that's a better question, in my opinion. How you deal with the patient are, they are confused and they're scared. And this is where you, as an EMT or a paramedic, can make a difference. Keep them calm, reassure them, don't lie to them. We're going to talk about that too. Don't lie to them. Tell them what's going on. Tell them what happened. Tell them what you found, what you've done. Tell them their status at the moment. And at the moment, Ben's doing much better, which is kind of where I'd put the focus. And if, in a limited way, I might tell him what he can expect when he gets to the hospital to the degree I know it, but I want to make it very clear to him that I'm not his doctor. The doctors will decide that, but there's certain things that are probably going to happen, but the doctor will be the ultimate arbiter of what happens to them. I need information from Ben. If you recall, Ben wasn't able to give it to the EMTs or the paramedic, at least before he woke up. I need information. I need him to talk to me. I need him to give me his history. I need him to give me his allergies. I need him, to tell me a little something about how he'd been feeling in the days leading up to this. I'm not going to go into it. I'd end up doing a patient assessment lecture. I'm not going to do that. There's a lot of things I need to know at this point. So I know how to better, maybe there's other treatment I need to render as a paramedic, but it gives me some idea and it reinforces that the treatment I've given so far is the correct one. And with that, I think I'm going to bring part 2 to an end here. Actually, in my original incarnation, this EMS Systems Part 2 went longer, but I'm having some rendering issues, and I'm hoping by cutting it a little bit shorter, it will fix them. So we'll see you on the next video.